end of decade of 90s, we started using this telephone thing with simple telephone lines. And because obviously since that time till today, there is shortage of radiologists. But that time when it started and started booming, then that time everyone was thinking that there will be definitely threat to radiologist job in future, because there may be people who will do this thing remotely, and in cities there will be a definitely problem for radiologists. But what we have seen over the years, the efficiency of radiologists started increasing because of this facility. And teleradiology, obviously, as Dr. Arjun told, is and what we saw is his work. So throughout the world, he's doing extensive work. So accordingly, like for Nidan also, it has been found very much helpful. We are even connected with so many centers in periphery, and even few centers in Africa and all. We are even doing that for our centers as well as outside centers. The work through this teleradiology, and it has been found very much helpful. Means I don't think that this is definitely we can say helping tool to work us more efficiently, and day by day I think it will be definitely more helpful people to everyone. So Nidan is also using this modality quite extensively. Thank you.
That's great.
Yeah.
And secondly, people had that, kind of the fear at the, flip of the millennium. Now, people will be jobless. What is your, experience with that?
uh, my experience as an entrepreneur in this diagnostic field, definitely, Miss radiologist, there is a scarcity of radiologists. Miss, we were
Absolutely.
we were assuming since every year that year on year there will be like ample availability of radiologists, but till now the scenario of 90s is same. Everywhere we are facing scarcity of radiologists, because there are even other modalities where ultrasound and all, because of all these PCP regulations, radiologist presence is must. So we can't offer this to technicians, and so radiologist presence is, I mean, job is definitely, I think, without threat, and it will remain, I think, forever without threat, because there are many things involved, not only this thing.
I fully endorse your view, Nitin, because I would say in other way that, in my, having all organization, in clinical practice of radiology also we are still feeling the scarcity. And in my teleradiology company, it's the Indian Teleradiology Hub, there
Right.
also we are facing, see, this is almost up to the 2 decades still we are having the scarcity of the radiologists. So, I don't think, at least we all as a community are safe till 2050. So nothing too much worry about that part, that what will happen to radiologist. uh, Dhananjay, good evening to you, and one interesting question for you. Even in my practice also, I have observed this. Many junior radiologists, when they are starting the organization of the teleradiology practice, after 6 months or 8 months, they also complain that, sir, we are missing that link with the clinician. And in a broader aspect also, those who are not actually doing the teleradiology, they are having apprehension that there is some missing link between the radiologists, clinicians, and the patients, and it may be having truth element also to some extent. But what is the other side of the story, and how we can minimize this miscommunication, Dhananjay?
Good evening, everyone. It's a very interesting question. Actually, when I started my teleradiology service, that was like 3 years back. I'm still young in this. So I was offered by few centers to report, but unfortunately, what happened was they are expecting in quantity, not the quality of the report. So I stepped back. I took a step back, and I thought I will decide what to do with my teleradiology company. So I recruited few subspecialized radiologists. Then I didn't approach. When I look for software, so first thing come to our mind is teleradiology software. So teleradiology solutions, I thought instead of taking software and working with software, we can work with them itself. So that's good thing. But they are not doing the work with the places where small centers, small hospitals in the rural place. So then I spoke to my team. Then I discussed like, okay, we'll just take up small centers and small hospitals in different small towns in Karnataka and Kerala. So later I approached a few softwares. So most interesting part is all softwares are done by the non-radiological or non-medical person. So their interest was, okay, we will give the case, we'll give the software, you just report. We'll give 1,000 cases or 10,000 cases per month, and we'll fix the rate. We'll fix something like that. So you just finish. I said like, whom we are reporting and which place we are reporting, who is the doctor, and they don't have any answer. No, we are not going to give anything. So later we decided, no, we are not going to accept anything. We'll just go through our friend circle. So I just covered few centers, and they are all known to me or known through my friends. So when they send cases, they'll message me with the history, request form, everything. And if the case is normal, then I'll just report it. If something I found like history is needed, then I'll call back and I'll ask the patient or clinician to talk to me and discuss. And then I'll send my report. So I'll not release my report, or my team will not release the report without consulting the patient or clinician for further history. Because ours is a small company and we don't have that much caseload, I think we are doing good.
Great. And Namita, you are having, so many hospitals across the India, and having the radiology department, and many radiologists, they are already recruited by Asia Columbia. So, as a chain of the hospital, how teleradiology helped you in a day-to-day practice?
Oh, quite a bit, I would say. See, we are about 13 hospitals in India functioning at different levels in various cities across India. So what happened is that when we were taking in more seniors, we realized that there wasn't much work happening in all the 13 hospitals to retain the seniors and to retain their interest, because we had seniors who were super specialized in musculoskeletal radiology, onco radiology, cardiac radiology, chest radiology. So when we started going out with teleradiology and got a lot more cases from there. So we were doing teleradiology for 70 centers in India, apart from the ones that we were doing in and around countries. We were doing for Africa, Middle East, Indonesia, Myanmar, a bit for France, and we did a bit for UK as well. We realized that the pool of cases that was coming in was quite intense, and therefore we were able to, actually, all super specialist radiologists were kind of satisfied with the kind of workload that was coming in, because they were able to see the kind of, in India, subspecialist radiology was not something very big at that time, and I'm talking about 6 years back, especially in corporate hospitals. So everybody was able to practice the radiology that they were trained into a much better extent. And we realized that this was helping us, because when DNB students came in, we realized that we were right on top of the list of people who wanted to do a DNB with us. So we got a very good number of students. We started a fellowship in cross-sectional radiology. It has actually helped us in retaining people, because one, there's a lot of caseload. You can see there's a lot of research and paper publication that we do because of everything that we see. We're teaching students now. We have a presence in the north as well. We've got students coming into us from everywhere across India to learn. And it has kind of bolstered all our knowledge and has been able to retain people for much longer because of kind of job satisfaction.
Great, Namita. Thank you.
So we have kind of built an entire pool of cases, and because we've been, we were completely PAX enabled from day one, from 2009. So we built this entire pool of cases that we can dip into and talk about and train on. So that has been a very important source, I would say, and that is why we were able to collaborate with somebody for developing a program for AI as well.
Great. And Arjun, one thing is, as we know, there are many extensive advantages in day-to-day practice for the teleradiology. And it's a big help not only to the clinician but eventually to all the patient. One of the biggest advantage of tele, what we can foresee and be used for almost last more than 2 decades, that is the use of teleradiology in emergency setting. What is your experience for emergency reporting for that kind of the emergency setup in US, in India, and in other countries?
So, Dr. Hemant, you're right. I think the focus of teleradiology and certainly the focus of our organization has been to provide emergency reporting services starting from day one. And I guess it partly relates to my own background as an emergency radiologist when I was working in the US. I was cross trained in both body and neuroimaging, so I kind of gravitated into emergency radiology. Uh, I think in emergency radiology, the challenge is the turnaround time. The report has to be delivered immediately for it to have any impact. So the challenge and the opportunity at the same time is to be able to report very efficiently and for anywhere in the world. The location is immaterial, and be able to give the report back within a period of 15 to 30 minutes, depending on the clinical scenario. So we report stroke cases from the US within a 15-minute turnaround time from wherever our radiologist may be located, whether in India or in the US or in Europe, or even we have radiologists in places like Turkey and the Middle East. So the main thing is to have a very smooth reporting workflow and a smooth image management system that allows the image transmission to be seamless and the flow of images to be uninterrupted, and the reports can be communicated very rapidly. So I think in the emergency setting, teleradiology has made a huge impact in, especially in things like areas like stroke imaging. Stroke imaging over the years has become very complex. In the old days, it was just a non-contrast CT, and you reported whether there was a bleed or an infarct. But now it is being used to guide thrombolysis. So we're looking for hyperdense MCA sign. We're looking for aspect score. So the complexity has increased, and of course now we're doing perfusion imaging, we're doing CT angiography. So we are dealing with large amounts of information which have to be analyzed and processed and reported very quickly. And because we are able to do that in a teleradiology environment, I see that as being one area where teleradiology is making a lot of impact. Of course, in general emergency imaging, whether it is acute abdomen for appendicitis or bowel obstruction or volvulus or any of the acute abdominal presentations, or chest imaging, whether it is pulmonary embolism, aortic dissection, all of these entities lend themselves very well to teleradiology reporting because the report can be done very, very quickly. And the advantage for the hospital is that they, especially if it's in the middle of the night, they don't have to wake up their radiologist who, at 3 in the morning, and they get an immediate report. And also they're able to have a verbal discussion with the radiologist, because the protocol in emergency imaging is that if there is any life-threatening situation, we have to also place a call in addition to sending a faxed report. So the communication loop has to be very, very close and tight. So as emergency medicine evolves and develops, I think emergency radiology is also evolving, and emergency teleradiology is increasing in impact. And for us, that has been our focus area, and for me personally, a matter of great interest and passion.
Great. And Arjun, as from beginning you are involved in teleradiology. One technical question is, uh, many people, they are having question that, what is the difference when you are using the server for the teleradiology solution, or if you are adapting to the cloud-based services, what is the difference between that, in a layman language?
So that's a very good question, Hemant. I think over the years, that and the transition has been from enterprise model to cloud model, and that is related to the fact that the cloud has become a very robust and powerful technology. So the advantages of having your data on the cloud are that there is redundancy, because if you have a server crash in one location, if you have all your images saved in an archive in your premises, and there is a technology issue, or God forbid, some kind of force measure like a fire or a flood or something like that, then all your data can be lost. Whereas having it on the cloud gives you complete redundancy and security of data protection. Second thing is that it allows for very easy access from anywhere in the world. I mean, that's the whole benefit of the cloud. It's not constrained by local network constraints. So the redundancies in terms of access have become very good. And you have these large data providers who host data, who can do it at a low cost. So your cost value is also obtained by using a cloud solution. So overall, I think the cloud is the direction in which teleradiology is moving, and correctly so. And it allows us to work, especially in a national or a global kind of an environment. The larger the scope of the practice, the more the cloud adds value. If it's a single institution with a few hub and spoke model within a city, it may not be so much value. Although again, I feel that in terms of providing redundancy and security, it is a good way to go. It also allows a cloud model allows for a pay as you go kind of a solution. So instead of investing in large amounts of hardware and infrastructure, you can utilize a provider and so you can start your teleradiology service without any large infrastructural setup costs. You can literally, from the first scan, you can be cloud enabled and start reporting. So for an individual radiologist wanting to start small and scale up, a cloud model of teleradiology, I think, is an optimal way to get things.
Great. Thank you, Arjun. And Dhananjay, of course, we are having the server, we are having the cloud, but in Indian setup, especially, when we don't have a radiologist 24/7 sitting on the computer or the laptop, do you think the hybrid solution, as far as the technology is concerned, use of the WhatsApp groups and transferring the video and the images on the WhatsApp, does that help to some extent teleradiology in the rural areas, in your experience?
So what I say is, WhatsApp, they'll send the videos just for a quick review, not for the report, and we don't give oral report or message reports. So what we say is, you just note this kind of problem in this area. So further report will be followed in few minutes or 15 minutes. So this WhatsApp group will be helpful when they want an immediate opinion. For example, as we said in emergency radiology, so they want to get an immediate opinion for an operation. For example, a trauma, there is a liver laceration, spleen laceration, or hemoperitoneum. So any surgeon wants to immediately, they want to explore it. So for that reason, they want report or some oral reports. So I give oral report saying that, okay, you can go ahead with this. There is this kind of laceration or fluid is there. And so as we know each other, then they trust our oral report and they'll go ahead with it. So once we send the teleradiology report, then they'll come back with next day saying like, okay, as per your oral report, we went like this, and it was a crucial time, and we saved the patient life. So this is the experience what we get with this WhatsApp group, any other social media group.
That's see, basically in my experience also, such a social media platform nowadays, it's a big boon to have a communication channel, especially between radiologist and clinician, where you can convey immediate images and video, and with associated reports or a couple of line reports to your clinician doctor, and they can start managing the patient. So it's a big boon as far as the management of the patient is concerned. Of course, we need to have very formal report of the as a radiologist we need to give them and all that. It may take some time, but in an emergency setup and otherwise also, from radiologist to clinician, it's a new channel is opening up with such kind of the social media kind of the tool what we are having. Nitin, you are having not only the radiology setup but the other hospitals and the healthcare system also. So how you rate this teleradiology solution from radiology report point of the view, or as a part of the telemedicine as a comprehensive module? So in your organization, how you are taking optimum utilization of this technology of teleradiology?
Yeah. See, means teleradiology, I think we can say that it's a means origin of telemedicine. Means the idea of telemedicine must have derived from teleradiology. So, this telemedicine, if you see, telemedicine isn't, though it's widely used in this COVID era, but many people started using this even in states and few other places. States they had few reservations because of some privacy of patients and all, but they even started using this before few years. And even in India, miss, or we had worked extensively on that this telemedicine thing uh, by taking this idea from teleradiology itself. Though we started that in 2000, this teleradiology solutions, but telemedicine, I think about 2010, we have submitted an extensive report to government of Maharashtra and given solutions to use this telemedicine thing in rural hospitals and PSCs run by government. And at few places, even government of Maharashtra utilized that thing. Means even this X-rays and all those reporting, and even teleconsultation through the consultants available at district hospitals. Obviously, there were few, I think, setups were guided and served by us, means our team also. So that way, obviously, this telemedicine used previously and now, and I think in future it will be definitely of larger use, like teleradiology. And with this, whatever we say, the future use of AI and all, it will it will be widely used in tele medicine as well as teleradiology. What we say means it will be just like a long fruit. What we say, so that will be additional help for radiology community as well as hospitals. Uh, I think it will be of very wide use, very much helpful.
Right. Thank you, Nitin. And Arjun, as we all know, AI is, it's coming in a big way. It's already, chipped in so many different regions of the body, and we are doing very efficiently as of now also. So how you look forward that, AI and the teleradiology, will they work together or whether they will work against each other in the future?
Very interesting question, Hemant. I think the my personal view is that they will work together. They're very synergistic, and I'll tell you why. I think because teleradiology, for one thing, is kind of the precursor for AI. Over the last 20 years that we've had teleradiology, we have seen the same challenges which are leading to the AI revolution. Basically, the worsening of the radiologist shortage, the increase in the amounts of data, the increase in the complexity of data, the need for more quantifiable imaging metrics, and the need to compare current with prior studies. All of these have been increasing. So the workload of radiologists has gone up so dramatically, and teleradiology is one way of addressing it, but it can only take us so far. And I think AI is ultimately the way forward in to make bring work-life balance back into radiologists' lives. The way I think the two will go together are, one is that using a teleradiology workflow that is AI enabled allows the AI algorithm to be utilized in the maximum benefit in the sense that it allows it to be deployed over a very large area network. So I think one way of looking at AI is that it is it is in the in the modality itself, and it provides the immediate result. But the other end of the spectrum is, I think, when it is integrated with the teleradiology workflow, it allows, especially in an emergency kind of environment, for prioritization and triage of studies which are, which could get delayed in reporting. And by highlighting them and bringing them to the top of the radiologist's work list, the reporting can be significantly expedited. Also, from the quality perspective, detecting small intracranial hemorrhages, fractures, and so on. These are all areas where AI has already started to make its impact. In our own organization, we're looking at some of these entities and developing solutions for intracranial hemorrhage detection, fracture detection, pneumothorax detection, pneumonia, pleural effusions. These are some of the problem areas that we're working on. And I think the opportunity is for a improving turnaround time of reporting, improving radiologist productivity, and improving radiologist accuracy. So there's a threefold benefit, and teleradiology allows this benefit to be realized to its maximum. Also, from the perspective of teleradiology already being data driven, it's large volumes of data flowing across networks. So it's a good ecosystem for an AI algorithm to be both developed as well as tested as well as utilized. So I think teleradiology is almost like a culture medium or a laboratory which will allow AI to really reach its fruition.
Great. And Dhananjay, in your experience, how the deep learning is going to affect to teleradiology?
Uh, Deep learning will not affect the teleradiology. It will assist and it will help and improve the diagnostic accuracy. So we just started application of deep learning and artificial intelligence in our center. So what we did was, instead of doing the artificial intelligence and deep learning, which already many companies are doing, so I thought of giving chances for young people to do a remote internship, especially for technical guys, and also research assistant from the medical background. So it just initially started maybe a few months back. What I realized was there are very young people, enthusiastic people. They want to do a lot of work in deep learning and machine learning and artificial intelligence. So, but they're not getting the platform just because they're not having experience and all, and they're not getting the proper guide. So we made a team of some software IT people, and from medical side with two or three people. We just started like we start instead of applying directly from so many sources, will make the students or interns to do by themselves and start creating neural network. Actually, this was a good idea. Initially, I thought, okay, it's slowing too much because I started in June. I thought I will develop something in 1 or 2 months. Then I realized like there are so many companies doing it. So what is the advantage of doing it by myself and sharing it? Then I thought, okay, instead of that, I will share with younger people, younger generation students, like final semesters, engineering students, or those who have passed MBBS or just finished radiology residency. So it will be much helpful for them. And all these things can be applied anywhere to teleradiology and make it helpful for the diagnosis and interpretation.
Great. Uh, and as we all are cruising through since last few months, and the complete deadlock in the world because of the COVID. After March, after the lockdown, we restarted the services on a regular basis gradually, and then after again, we are resuming as far as the healthcare is concerned to almost to the normal level. So what is the impact in diagnosis of COVID using the teleradiology? Number one. Number two, during COVID, how teleradiology help for diagnosis of other non-COVID patients also? I would like to ask this question to Namita. Namita, please share your experience and enlighten us.
Right. So, Dr. Patel, what happened is that I would tell you the experience of Bangalore. Bangalore actually was behind the curve as far as COVID is concerned compared to the rest of the world and also rest of India. So what happened with us is that we started seeing cases in teleradiology much earlier than we saw them in our hospital. And at that time, because I was the chief of medical services as well, we were planning and plotting what to do when a COVID patient comes to the hospital. Because of our visibility and seeing these patients so often, we were absolutely prepared as to what needs to be done when we start seeing the typical features in us. So that gave us a kind of confidence that when we will actually see those in our patients, we will know what needs to be done. Apart from that, the fact that not everybody had to be there in the hospital all day was a big thing, because up till then, teleradiology was supposed to be something which was done remotely on remote scans. With COVID, it became an internal teleradiology as well, where only one person was supposed to be in the hospital to take care of emergency ultrasound, while the rest of us were working remotely from home. And that helped us limit our risks. And also, as when I was in the administrative thing, I also had to see what was the utilization of PPEs. So if you had six staffs and all of them are roaming around PPE versus you have two of them, and the others are not at risk, so that was another added benefit from teleradiology, because we could all be minimizing our risks and actually working from home, and that became the norm. So COVID in one way gave us the external stimulus which made teleradiology an accepted norm compared to what it was earlier. So while Dr. Arjun was much ahead of the curve as far as teleradiology is concerned, it is now caught on from all hospitals' point of view as well, where people were comfortable just calling clinicians, calling the radiologist at their home and asking them for reports rather than seeing something. What it did do, although what I saw because of the impact of COVID, is that we saw a lot of, while we were in teleradiology, we saw a lot of emergency cases. So in a span of about 20 days of the first, of the lockdown, we saw liver abscess ruptures, perforated gastric cancers, multiple abscesses, ectopics, and IUDs, all of that, which was kind of not being brought to the hospital earlier because of the fear of COVID. We saw a lot of those cases on teleradiology. We saw a lot more perforations. We saw duodenal ulcer perforations. People who were wary of coming to hospitals with acute minor abdominal pains, appendiceal perforations, were coming to the hospital in emergencies. So that kind of, we saw a lot more emergency cases at that time, positive emergency cases. And also, it kind of set the norm for teleradiology to be accepted for reporting hospital cases by hospital radiologists sitting remotely as well. So that was my experience of the impact of COVID. And then what it has done is that if you read the studies, then the teleradiology market is expected to increase threefolds in the next
Right.
5 years because of what COVID has done to
Right.
increase its acceptance amongst everybody. So that is a very good thing for us, because as radiologists, because we deal with images, which is digital transfer of data. And if there is lossless data and a great internet provider, service provider with a cloud for us to view the images, then we will actually be we are in a much better place today because of the COVID than we were about last year.
Great. And Nitin, as you are in the healthcare system, the month of April that was full of fear and panic because of the COVID,
Right.
and it was difficult to restart the practice of the radiology.
Mhm.
It was difficult to regain the faith of the clinician, faith of the patient that going to the radiology department is safe to do, because in the same a 20 by 20 feet room. Many patients, they were keep shuffling, and they had that doubt, and they had that fear also, that there will be chances of the cross infection, and it may be in a big way. So how you dealt with that kind of the situation in month of April 2020, when you resumed again to the normal mode on the normal new for the radiology practice?
Definitely, it was a great challenge, like arranging from the paramedical staff to obviously radiologist solution was available through teleradiology, but others managing the staff and even means assuring safety to patients and referring even clinicians that their regular non-COVID patient, if he is coming, or then how you can like keep him safe from other COVID patients done means probable COVID cases. So how we can safeguard them. So it was a big challenge, but obviously through whatever possible means, like means this one means disinfecting that room after every patient, then changing all the things, like bed sheets and all those things on the table, and obviously double masking to every incoming person in the center, then to the patient, and all that hypo sprays and everything, whatever possible means we try to assure safety to everyone, because more than clinically or scientifically required things, we had to do many things for just psychological sake of patient safety, because we had to show that you are safe, and we are using every possible tool to keep the patient safe from the probable transmission from other patients. And we were even at other departments, this ultrasound and all, it was a great challenge to assure patient safety. But we could I think at all our Nidan centers, we all, except one or two, we had to keep those closed, because in that area that was especially sealed area. So there we couldn't keep the centers continuously on. But at all other centers, we kept the centers on every day, even 24 by 7 at many places, and with whatever limited staff available. But as you rightly asked, it was a great challenge, but we could do that with all these possible means um, of safety to patients, as well as the referring clinicians, assurance to those people. Obviously, we must have seen that many of the clinicians were absconding that time. Means nobody was
Oh, oh,
ready to see patients. So it was a definitely great, but we could deal
okay.
nicely.
Yes. And one, important but less discussed kind of the segment of teleradiology is that sometimes the non-radiologist friends, they believe that just by having some investment they can start any business, and they do start business in form of radiology, or sometime in form of teleradiology also. Sometime in our country, in many PPP projects, that's the public private partnership projects, many non radiological, or for that matter non medical organizations, they have been involved in giving that kind of services. Now here they have very wafer thin margin, they are doing scan at very bare minimum rates. So it is out of question that they can pay healthy to any radiologist physically, and to cut short the input cost, they are adapting module of very cheap teleradiology services. This is serene, but this is the hard fact and the reality as on today. So how that affects, because it's quantity over quality, and we are striving for quality over quantity. Dhananjay, your ideas and your views on this commercial aspect of the teleradiology in 2020.
Yeah, I was approached by many non-radiology and other kind of professionals who have started teleradiology services. So when they asked me, can you do this much amount of cases? I said, okay, I can do any amount of cases because we have a very good team. They said, we are giving so much cases. Can you do it for this much amount of money? I said, that's not correct because you have to respect each profession. You can't give the lesser amount of money and we are, no, we are giving very large quantity so that you can have a
It's a
good amount
kind of
of money.
the
But
wholesale
this
business.
doesn't sound right. Yes, yes, yes. So what I said was like, if I do that work, so what about the next generation? So for example, if I do reporting for certain amount, they will cut short another 50 rupees, 100 rupees, and they said, okay, next generation, we will do this much, I'll give more number. And this is downgrading the value of radiologist. And we have to take care of our future radiologist and future generation also. They are the, like, taking care of the rest of the future generation population. So I feel like instead of taking all kind of teleology uh, offers, so I restricted myself to I have some certain rates and thing. I don't believe in quantity, so I'd like to give quality service. If you are ready to take it, but they are not ready to take it. I said, okay, it doesn't going to happen, and there are many people who randomly does this work. We can approach them. So I see many senior people in I have come across in certain part of the southern states. So they take up this kind of work and they make junior radiologist or some students to do the work and they finish the job. So quantity wise they will get work done, and but the quality there is no assurance. So this is happening. I've come across these kind of things, and I've heard from a few of my friends from North India and western eastern parts of India. I don't know how it will end up.
So, Arjun, do you think less than $5 anybody can report the MR? And if it is so, then how we can value the quality, and how to retain the standards. And basically, we all are professional people, and we need to stick to our ethics as far as radiology and the medical practice do concern. So, your views on this?
So, Hemant, we've kind of followed the Robin Hood model. So, we get our international practice. The revenues are more robust and they allow us to grow and scale. And within India, to a large extent, the work is delivered through our foundation. So we are supporting these hospitals in very, very remote places. Rural tribal populations, public health projects, where it's basically you're doing it as a service. So we're doing it through our foundation. I agree with you. In India, it's a very difficult market to function in because of the challenges of having to negotiate and ultimately collect. So there are a lot of people who default on payments. We've had many experiences where
True.
people have not paid at all. So
Absolutely, I
it's
fully
a
agree
tough
with you.
situation to practice in. I think I don't know the answer, but it's I think maybe some better some more regulation might be necessary from the perspective of possibly IRI or government to get to ensure that there is a proper business contract which is
True.
honored as opposed to current
Exactly.
situation.
True. I fully agree with you. And we are just running short of the time also. It's a very interesting discussion going on. But we are having last 3 minutes. And the last question to Arjun, because your vision in 1990 is the reality in 2020. I would like to know, same with the all radiology fraternity, they want to know from you how you look forward the future of teleradiology in coming 30 years, from we are starting with the 2020 to 2050, how we are going to have the journey in your own eyes.
You give me a very long horizon, Dr. Hemant.
I know, but
What
that's what we see. The time is
but
also running so fast.
no,
You
I
dreamt it
appreciate it.
just before 30 years, and we are here now. We just want to have part two of your vision, and we are sure we will be, partially to that extent.
The
Thank
past
you. Thank you.
experience.
Thank you. I think, from my perspective, I think if we look back, we would not never have imagined that we would be today where we are from where we started out. I mean, basically started with one radiologist in a room with one computer, and now we've grown to 20 countries, 150 hospitals, and close to 100 radiologists. So that I think the work has just come. It's not that you aggressively pursued it. It has just kind of flowed into a large extent. As Dr. Namita said, with this year has been a kind of an inflection point for teleradiology and all of telemedicine. And you also made this point that everything has changed now. I think acceptance of telemedicine in general and teleradiology in particular has dramatically increased. And so we're going to see very dramatic increases in utilization and numbers. We're already back to our pre-COVID numbers. For a while, everything was very, very slow, but now it's back, and it's like the pendulum has swung to the opposite, and it's continuing to swing. So I think the the workload on radiologists is going to continue to increase. I think use of teleradiology is going to be very, very necessary. I think all of radiology will ultimately move into a teleradiology kind of a model, not necessarily all the time, but at least as a support system. Every radiologist will incorporate teleradiology into his or her practice in some shape or form. Again, the incorporation of AI into teleradiology, I think, is also going to be a big game changer, because it will allow the reporting to be done more efficiently. So I think the combination of efficiencies in workflow and incorporation of AI will make teleradiology ultimately the the enabler for a paradigm shift for all of us to be able to practice, to be able to leverage our skills, our expertise, all our hard-earned training and experience, to utilize it more effectively for a larger section of the population, and to be able to deliver patient care with fulfillment and satisfaction.
Great. Thank you so very much, Arjun. And I thank all the panelists. One hour is genuinely less to discuss about, this great aspect of radiology, and there's the teleradiology. But we will keep meeting in such kind of the webinars and in the actual meetings also, and keep discussing into the more depth about the teleradiology. You all guys, you are inspiration for so many youngsters and the radiologists, those who are coming in the practice. And I'm sure this must be very helpful information to all of them. I thank you, Pratibha, and all team members of Elates for organizing this wonderful webinar. My best wishes for rest of the conference.